Let's look a little bit at the portal veins. For this, we have to talk about the Doppler a little bit because nowadays we do more and more Doppler. In a normal main portal vein, we have continuous forward flow. The liver is always available for detoxification of substances, anything that you eat, any breakdown products from the spleen, the gut, etc. So it's constant forward flow with a low velocity. If you did velocities, usually they're 15 to 28 or 30 centimeters per second. The flow is into the liver, shown here on this color Doppler. Red means flow towards, so we have flow towards the liver. It's an undulating pattern which reflects respiratory variation and may reflect cardiac variation. It's a slightly turbulent, rough, low rumble kind of flow. That's because it's located between two capillary beds, between the mesenteric venous system and the hepatic venous system. What's abnormal? Well, abnormal is when that flow becomes too pulsatile. It may then start resembling hepatic vein pulsatility, and that would mean that there's elevated right heart pressures and that there's transmission of pressure through the sinusoids into the veins. We can see this with tricuspid regurgitation. We can see it with moderate to severe right heart failure or pericarditis. The exception would be in the young child, where the liver is so soft and pliable that it can actually transmit cardiac pulsations and central venous pulsations from the heart. Here is an abnormal pattern of a main portal vein. Suddenly it becomes too flat, very flat and continuous flow with loss of that undulating pattern, and that's what we'd see with cirrhosis and hepatic fibrosis, where the liver becomes stiff and we lose that undulation. The hepatic artery, now let's look at the hepatic artery. The hepatic artery typically has a very rapid systolic acceleration. It's a nice arterial pattern. It has continuous forward flow of blood into the liver throughout the cardiac cycle. So it has a low resistance pattern. In other words, fairly high diastolic flow because blood freely enters the liver. It is always in the same direction as the main portal vein flow. So on color Doppler, these two vessels, the artery and the main portal vein, are always the same color. So if you set your color map with red, meaning towards the transducer, both will be red. If you turned it blue, as meaning towards the transducer, both should be blue. But you should not have one red and one blue, because of course this has nothing to do with oxygenation, it's direction. It's also interesting that the portal vein and the hepatic artery sort of have a mutual understanding between themselves. The portal vein carries 70 to 80% of the blood into the liver, whereas the hepatic artery only brings in 20 to 30% of the blood flow. But the artery brings in the fresh oxygenated flow, but the portal vein brings in deoxygenated flow from the splenomesenteric system. However, it's carrying a lot of flow. And there is a certain homeostatic mechanism between the portal vein and the artery. So if the portal vein flow decreases, there's a signal given to the artery to increase blood flow. So as a liver becomes sicker and develops more cirrhosis and blood flow cannot come in through the portal system, the arteries tend to enlarge to bring in more flow. Okay, so you saw the normal waveform. Now here's an abnormal waveform. The waveform becomes abnormal when the resistance becomes increased and diastolic flow drops. So we see such a pattern after eating, postprandial. We also see this with portal hypertension, more resistance in the liver, and more importantly these days, transplant rejection. We will pay attention to the arterial waveform. Now, another way that the artery has abnormal Doppler is post-liver transplant. That's when it becomes important to us. If we see a tardus parvus waveform after liver transplant, this is an abnormal finding. We would see low upstroke and fairly low velocity, which means that proportionately the diastolic flow is elevated. So we have a prolonged systolic acceleration time, and then this tardus parvus waveform. What it means is that there is a hepatic artery stenosis, anastomosis. There's an anastomotic stenosis post-operatively. So we are not seeing the flow through the stenosis itself, but we are seeing the flow downstream from the stenosis when the flow has lost energy and is trying to relaminarize and is weak. And that's why we get the tardus parvus syndrome. So we don't actually see the stenosis, we just see the effect of the stenosis downstream in a transplant. Now let's look at the hepatic veins. Normally, the hepatic veins drain towards the heart. That's why they're registered here in blue, away from the transducer. And on the spectral, they are also registered away, usually below the baseline, towards the transducer where we have systole, diastole, but we have above the baseline when we have the atrial kick. So we have systole, diastole, kick, systole, diastole, kick. The normal Doppler here, the reason for this pulsatility is because it reflects respiratory phases and variations in central venous pressure that is transmitted from the right atrium. It also reflects the compliance of the liver parenchyma, giving us this triphasic waveform, systole, diastole, kick. Be careful though, because deep inspiration or Valsalva may reduce this pulsatility and dampen it, causing you to think there's a problem. So the waveform becomes abnormal when we lose that triphasic flow. When we lose that, we know that there's elevated right heart pressure. We lose the oscillations or the amplitudes. We can actually lose the atrial kick. We lose that first, and then the whole waveform starts to be more dampened, eventually turning into a monophasic abnormal waveform that is flattened and actually almost resembles a portal vein flow. We call this portalization of hepatic venous flow. So it should be a nice pulsatile pattern, and all of a sudden now it's flow. It's because the liver is stiff, the liver is non-compliant, and does not allow this wave to be reflected in the vessels. So now let's talk about sonographic liver patterns. There are basically three patterns in the liver: the normal pattern, the centrilobular pattern, and the fatty fibrotic pattern. We already discussed the normal pattern. Now there's the centrilobular and the fatty fibrotic. If you look at it closely, this one has too many portal vein walls. This one doesn't have any. And let's talk about the reason for that. In the centrilobular pattern, what happens is the liver is edematous, so that the parenchymal cells, the sinusoids, the hepatic cells, become edematous, increase in water, drop their echogenicity, okay? And that makes the portal vein wall stand out, giving it a starry night appearance. So you have these bright walls standing out in a dark background of the night sky. So what we see increased brightness and of the portal vein walls, and we seem to have more portal vein walls. Now the liver does not make more portal veins, it's just that we see them because now we have more contrast. This pattern is seen with acute hepatitis, also seen with acute right heart failure. You may see it with infiltrative diseases of leukemia and lymphoma. We used to see it with toxic shock syndrome, but we don't see that much anymore. And we can see it with 2% of normal cases. And the 2% of normals are usually the young, thin adolescents, maybe 15 to 20 years old. they're so easy to scan and see so well that they look abnormal, and that's easy to tell. The patient is healthy. There's no liver function test abnormalities, so those would be normals. Beyond that, we have to be cautious and rule out liver disease.